participants for joining. Be here for learning with us. Today's topic is very important because whenever people say about palliative care, they always talk about pain management. We'll be having two sessions, but today we'll be focusing a little bit on the assessment and the concept of pain when we talk about patients with serious health related suffering. And we'll start with the management part. The part one will be done today and we'll be continuing tomorrow again. I'll hand over to Dr. Rajagopal. Sir, over to you. Sir, you're muted.
Thank you, Sri and Sri. Sri, that's very interesting what you said just now. Generally, people associate palliative care with pain management very often. So yesterday we talked about the concept of palliative care and what it is. We said that it was about improving quality of life by preventing and treating suffering, which means by treating pain and other symptoms, psychological, social, and spiritual issues. All this is important. So why do people always think of palliative care in the context of pain? The significance, one, pain is the most common symptom of all symptoms that patients with cancer come from. And in many other diseases, pain is the most frequent symptom. Fact one. Fact two. Pain can be overwhelming. Pain can be beyond your power of imagination. Please think, what is the worst pain experience that you have had? It may be toothache. It may be the pain that you had after a fracture in an accident. It may be a post-operative pain. It may be a labor pain. Maybe some of you have had a pain that is more intense than what your friends would have had. Please remember, pain can be very different from person to person, and sometimes it can be so overwhelming that it will occupy every square millimeter of your mind space, leaving space for nothing else. The person becomes just the pain and nothing else. You treat that pain and the person emerges again. It can be almost miraculous. So very inappropriate that Sri and Sri have put in pain management as the first item on the agenda. Let me share my screen and take you through a bit of pain management. Please remember, pain or any symptom should be taken in the context of the person. I don't know if I mentioned this yesterday, but Sridevis have heard this 257 times. Eric Castle, a famous Australian doctor, says, it is not bodies that suffer. It is persons who suffer. It is persons who suffer, not bodies. It is an individual experience. Some people may tolerate pain less emotionally. That's not a fault. You shouldn't judge them. Because you have been able to tolerate a toothache very bravely, doesn't mean that Sri Priya also should tolerate that as well as you. You two are different kinds of people. People have a right to be different. If somebody is suffering more than you, that's not their fault. If they are suffering more, they should receive more, they deserve treatment. So this man, his problems may be many. He has deep-seated gnawing pain in the right suprascapular and infraclavicular areas. It doesn't mean that that pain is only caused by the passage of electrical impulses. It's also caused by his worry about his children. When he is sleepless, the suffering is more. That's all natural. And the most cruel thing that you can say to a person, to him is, hey, you are an adult. You must learn to tolerate some pain. The feeling that nobody understands me can be very, very demoralizing. So, we are going to talk about him, but specifically in relation to his pain experience. We will talk about why he has pain. He has somatic cell carcinoma in the upper lobe pain. And also we'll begin to talk about how it can be treated. IASP is the International Association for Study of Pain. International Association for Study of Pain may be the most widely recognized and authoritative organization in the field of pain globally. They bring out guidelines and their definition is famous. Unfortunately, it's a bit wordy, a bit like the WHO definition of palliative care. An unpleasant sensory and emotional experience associated with or resembling that associated with, oh my God, actual or potential tissue damage. What I'll do for you is to make it a little less prominent. Let us try to remember this. Sensory and emotional experience, very important. Sensory and emotional experience. The emotional experience is not the person's fault. It is for you and I to identify it and treat it also. Associated with actual or potential tissue damage. Okay, any comment or question? Potential tissue damage, there may not be an actual tissue damage at the moment. Like somebody with a history of post-herpetic neuralgia, the lesion has healed, but the neural damage continues to cause pain. Please remember, our objective is to make him feel better, make his wife feel better. Our objective is not only to treat that sensory impulse. We want to improve the quality of life. And of course, as I said, the pain can be overwhelming and we may have to identify and treat it first before we are able to identify his emotional or social suffering. And that experience is what we are going to treat. Sorry. Just a little bit about electrophysiology of pain. Afternoon. I know it is cruel to bring this in, but this is essential. Please look at the bottom picture. When you prick your finger with a pin, as you do at times for a blood sugar check or any blood check, or accidentally, when you do that, the trauma trauma is caused to the nociceptor. Nociceptor is the high-sounding word that we use for a nerve ending that senses pain. Okay. Your pinprick, electrical impulse generated in the nerve ending. The impulse travels through the peripheral nerve to the dorsal horn of the spinal cord. Listen, I am leaving all the complicated stuff behind. I'm not going to talk about the different kinds of receptors or anything. For our discussion today, what electrophysiology is absolutely important. That's what I'm going to talk about. So, electrical impulse, Dr. Satyendra's pin caused an electrical impulse to be generated in his nerve ending, which travels through the peripheral nerve to the dorsal horn of the spinal cord. Now, from here, this is where the impulse gets modified, sort of organized, sort of what happens in a central console of a computer. And from there, the impulse, okay, they don't forget all the crossing, etc. Impulse travels to the brain. Which part of the brain appreciates pain? Put it upon the chat box. Okay, we may not have the time. Thalamus and the cortex. Coarse appreciation of pain occurs from the thalamus, and finer localization of the site and the nature of pain occurs at the level of the cortex. Repeat. Nociceptor, dorsal horn of the spinal cord, modification of the impulse, pain appreciation in thalamus and cortex. Okay. Listen, I'm not going to talk about all that happens with the pain pathophysiology. That's not the intention. There is a lot more to learn. I hope you will read up more about it. I hope you will get the Indian primer also, and there also a little more details are given. Can I move on? Now I have a question for you. Suppose the pinprick continues constantly. Dr. Satyendra's pin comes and pricks the finger, goes out, comes in again, goes out, and constant, same depth, same frequency. Or it can be a pressure applied over a part of the body. It's constant, not changing. If the stimulus is constant, what would happen to the pain? Remain constant? Pain will decrease over time, or will it increase? Sri?
It decreases over time. It gets tuned out, something like that.
Sorry, who said that?
Sir, Sitaraman, sir.
Sitaram. Sri, do you want to administer the poll?
Yes, sir. Launching.
Dr.
Okay.
Sitaram has already biased all the participants. Let us see how it goes.
I didn't know there was a poll
No,
coming.
I'm sorry, my mistake, not your mistake. Thank you for the immediate response.
It is as the same as yesterday. You just have to choose your option and submit the poll, launching the poll, right?
Sri, what's the total number of participants?
Sir, we have around 46 joined in, 45 joined in right now. Sir. And
Ladies and
30.
gentlemen, am I to suspect that 8 people have gone into post-lunch somnolence? 38. Okay. Only 7 people are sleeping. Nota, 7 nota. Dr. Sitaram, you certainly were very effective. Unfortunately, gentlemen, though that can happen, Dr. Sitaram's answer, which was given by 65% of the audience, would also be correct if it's a minor pain. I developed some shoulder pain some 20 years back. First, of course, being a doctor, I suspected a malignancy. That's what we all start with. And eventually, somebody said, just said, hey, forget it. It's nothing much. It's a minor cervical spondylosis. So I rubbed my shoulders and learned to live with it. I have hardly used to feel it till recently. So Dr. Sridharam is correct that if it's a minor pain, you may get used to it and learn to live with it, and then the suffering may be less. Emotionally, you are coping with it. But Dr. Sitaram and the 25 other people who went with you, most of the time, in any severe pain, the third answer is correct. And I'll explain how it happens. Sri, can you close the phone? Okay. Before that, let me ask you, why did God Almighty give us pain? What's the purpose of pain? Does pain have a function? Is pain useful at all? Rachel?
Sir,
Rachel, are you there? So, okay, kya? Anjana, you were about to say something. Oh, Dr. Bhan Prakash has written.
yes, sir. It's
Yes,
actually
yes.
a protective.
Protective. Yes, yes. It protects you. Actually, this is a life-saving protective thing. Do you know that there's a very rare genetic disorder where their children are sometimes born without being able to appreciate pain? And what a horrible thing. They will take the finger to a flame. They'll get injured and they will not know. And children born without pain, though it's fortunately very rare, never live more than 2 or 3 years. They die. So you're absolutely right. Pain is protective. So what's the pain protecting you against? It is giving you a warning. When Shilpa Narayankar is feeling a pain, Shilpa gets warned. Hey, something is wrong. So like me suspecting cancer and running to the doctor, Shilpa would get to a doctor. Or if it's your cooking utensil is too warm, you withdraw your hand before too much of damage. It helps you to escape from the trauma, right? But if it's cancer, what protection is there? It will warn you. You cannot run away from the pain, so you run to the hospital. So in any long-standing pain, the protective mechanism actually causes a worsening in the problem. Pain keeps on increasing, and that happens due to a variety of mechanisms, which I'll show you. The time, area, and intensity of pain increase by several mechanisms. Okay, we said this was a nociceptor, right? With time, silent or sleepy nociceptors that Anjana did not know or does not know exists in your body wake up. Silent or sleepy nociceptors are like the reserve police. What do they do in normal days? Just do their routine parade and eat and go to bed. But when there is a riot, they are on the forefront.
एक्चुअली हमारे में सिर्फ अंशु मैम है जो पहले से हैं, तो इसलिए उनको कंटिजेंसी में डाल दिया.
Nidhi, Nidhi, you are broadcasting to the group. So the silent or sleepy nociceptors get recruited. Not only that, the nociceptors get sensitized, more and more sensitized. If today it can appreciate 10 stimuli, the same stimulus, with the same stimulus, tomorrow 100 impulses will go from here. And what the neurotransmitter that is causing the sensitization, there are many, but the most important, anybody? Prostaglandins. Which is how NSAIDs work. Non-steroidal anti-inflammatory drugs block prostaglandin release and decrease the pain appreciation of the nociceptor. Many of you must be swallowing so many NSAIDs. And that's how it works at sites of inflammation. Secondly, it also sensitizes the dorsal horn cell, making it more and more sensitive. So that today again, if one impulse goes from here, one impulse goes from here to the brain. Tomorrow it is 100. Day after tomorrow it's 100,000. So, in an effort to protect you, with the same stimulus, the body gives you more and more and more pain. So, your patients, Dr. Sitaram, if somebody has a fracture of the rib and comes to the casualty with the pain, you ask them where the pain is, they'll say it's right here, they'll point to the place. Tomorrow you go on rounds and ask him again, they'll say my whole chest is aching. The pain is increasing in area and in severity. This is something that we have to remember. Why? Why do we have to remember this? What's the point? One, we will believe the patient when he says or she says pain is increasing. Two, any other reason?
Central sensitization occurs.
Yes, this is central sensitization. Absolutely. Who said that?
Dr. Parveen, sir. Shahida Parveen.
Parveen, absolutely right. The gradual sensitization of the dorsal horn cell, or in the case of cranial nerves at the brain cells, that is called central sensitization. The ability to increase appreciation of pain that occurs with constant pain. So, what's the practical application? So, what do you do about this?
So we should start treatment for pain as soon as it's there. Otherwise, it will increase. So to prevent that central sensitization, prevent the pain to become chronic, we need to treat it as soon as it appears.
Everybody, a point note kiya jaye. Priya, absolutely right. If pain analgesia reaches early, it's so much easier to treat. Priya, you are an anesthetist, right?
Yes, sir.
Priya, can you do even better? You said as soon as pain starts. Anything you can? Huh?
Preemptive analgesia.
Preemptive analgesia. Priya, please, for the sake of the non-anesthesiologists, will you please, in a couple of sentences, say what is preemptive analgesia and how it is done?
So it is the analgesia we give for anticipated pain, like in perioperative period that we anticipate due to surgery or due to wound, the pain will happen. So we start the treatment beforehand. So
the meaning, say you may put in an epidural catheter.
Yes.
Or you may even give an opioid prior to the surgery. If you do that, the result in the postoperative period is amazing. The difference will be great. So, yes, so the main message given by Priya, treat the pain early. Priya, if it is, okay, we started early. If it is a continuous pain, post-operative pain, so you start the analgesia early and then you write an opioid or whatever medicine it is, SOS, to be given as required. Is that good enough?
No, sir, we give the continuous treatment.
By the clock.
Yes, sir. By the
Medicines by the clock, pain prevent. And then you will see that after the first 2 days, the pain experience may be very little. Whereas the person who received poor analgesia will continue to be in pain for a week. Treat pain early. In all continuous pains, give analgesics by the clock. Okay. Whatever analgesia it is. Just think paracetamol, ibuprofen, Sri Priya, Paul, please. You.
Yes, sir. Just a minute. There is some problem with my glass.
Sri Priya, all the participants are from within India, right?
Yes, sir. Only Indian participants.
Okay, okay. Hold rate is increasing, Sri Priya. Notas are less now.
They have decided to
40, 40.
stand
Okay.
at the take a stand, sir.
So, thank you, friends. I'm sorry to the 3 people who said SOS. No, 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 no. Continuous pain. The message is treat pain continuously. The second dose must go in before the first has stopped acting. Because if you allow the pain to come back in between, the sensitization is happening, both in the nociceptor and in the dorsal horn cell. So, if the pain is continuous, that is the question. See, if the pain is continuous, paracetamol giving SOS is not enough. The second and third answers are correct. It can be cured 4 to 6 sets. If it is a long term, several days, maybe 6 early is safe. The duration of action will be somewhere between 4 to 6 hours. But if it's your child having a fever or something, your pain, and maybe for the first day or so, 4 hourly should be okay. But ladies and gentlemen, the other 3, 8 hourly is not enough for paracetamol. This is a common thing that is done. We all are used to writing everything TID, on TID. Just not enough with paracetamol 4 times a day. Oh, strictly 6 hourly, etc. may not be practical. We don't want the patient in pain to keep an alarm and wake up at 6 o'clock, 12 o'clock at night, and then fail to go to sleep. Not good. But 6 hourly is 4 times a day. What I would advise them is try to get an early breakfast and have the first tablet. When you have your dinner to bedtime, have the 4th tablet. In between, take 2. Okay. These are some of the commonest painkillers that we all take. I don't think there will be anybody in the group who has never had a paracetamol or a NSAID in their life. I must also admit, sometimes paracetamol is included among NSAIDs. And that's because they also have a prostaglandin inhibition action. The difference is paracetamol has a predominant central prostaglandin inhibition action with very little peripheral action. whereas all other NSAIDs, starting with your aspirin, have a predominant peripheral action. In clinical doses, they have very little central action. So, shall we take the poll about ibuprofen also, Sri?
Yes, sir, logical.
The two people who answered SOS, please remember the pain is continuous. The pain is continuous. We do not want peripheral sensitization or central sensitization to happen. If the pain is severe enough for the person to demand pain relief, it has to be on a continuous basis. And friends, to the 4 people who answered Q4H, I'm sorry, that'll be too much. 6 to 8 hourly is acceptable. Paracetamol, ibuprofen acts for 6 to 8 hours. Of course, with all these, you always ask them not to take it in an empty stomach. Shall I move on? I think the person who have a problem with it in the sense ordering SOS at the time of the discussion towards the end, please bring it up. Let us talk about it. Now, here is the man whose picture and the wife. You remember, I showed the man's picture with his wife. A 35-year-old father of 2 young kids, diagnosed as commercial carcinoma of the upper lobe of the right lung, and has deep-seated gnawing pain over the right supraclavicular and intraclavicular areas. Local pain. This is where he has a cancer, he has pain. So, pain can be essentially of 2 types. Essentially, it can be classified in several ways. In this case, depending on the site of origin, this is the pinprick that we talked about, or the cancer sitting there and pricking the nerve ending. That is nociceptive pain. Can there be pain without stimulation of the nociceptor? Suppose there is an abnormal electrical impulse generation anywhere in the nervous system, that would be neuropathic pain. Pain that occurs by stimulation of the nociceptor is nociceptive pain, and pain that is caused by abnormal electrical impulse generation anywhere in the nervous system is neuropathic pain. Okay. So your pinprick was essentially a nociceptive pain. The person on the operation table, Priya's patient on the operation table, undergoing laparotomy, has a nociceptive pain. When you get a fracture, you have a nociceptive pain. When you burn your finger during cooking in the kitchen, like I do all the time, that is nociceptive pain. Shada wondering, am I cooking in the kitchen all the time? No. When I do. If I ever enter there, I'll come out with a burn. That's what I meant. And that is nociceptive pain. Hey, friends, so what's a neuropathic pain?
Due to nerve compression,
Exactly. Like an example?
like any mass or
Okay. A cancer or other mass pressing on the spinal cord or a nerve. Okay. It can be a peripheral nerve also. Good. Anything
Like
else?
a diabetic neuropathy, sir.
Diabetic neuropathy. The other is compression. Here the nerves are becoming abnormal, so that in the peripheral nerve, what Priya mentioned can be in the dorsal horn, in the spinal cord also, whereas in the periphery also it can happen. And then it is neuropathic pain. Well, if you want to bring in 2 more examples, I
Cervical
mentioned.
disc disease.
Sorry,
Cervical disc disease.
cervical or lumbar disc disease, protrusion of the disc compressing the nerve roots, or even the spinal cord. Yes, very good. That's also nerve compression. Did somebody else say something?
Phantom limb sensation in amputated limbs.
Phantom limb pain, clear kind of pain. Phantom limb pain, abnormal impulse generation, right up there. Okay. Okay. Trigeminal neuralgia, osteopathic neuralgia. Sorry, Anjana?
Neuralgic pain, sir.
Neuralgic pain is just another term for neuropathic pain. Okay. Neuralgia, algia, pain from the nerves. Any neuropathic pain, like, okay, trigeminal neuralgia, osteopathic neuralgia, etc. So, I mentioned this at this stage because the management can be a bit different. Neuropathic pains very often may be partially responsive or not responsive to ordinary painkillers. So it is not as if for every pain you can prescribe the same analgesics. This identification will become necessary. How will you know? These are some typical features of neuropathic pain. Quality, burning, shooting, lancinating. These are some typical descriptions. Shooting down the leg. 45 people here, at least 5 of you must have had a sciatica at some point of time. Pain shooting down the leg. Or burning pain, particularly in any, it can occur in burns also, but also burning pain occurs in tumors, compressing nerves, etc. Lancinating, like people pricking with a pin. And one of the diagnostic feature, it will be occurring in the area of distribution of a nerve or a group of nerves. If it is diabetic neuropathy, it will be in the periphery of the limbs, most likely to start with, where the least blood flow reaches. If it is trigeminal neuralgia, it will be in the area of distribution of the trigeminal nerve, or it can be in one of the branches, only in the maxillary branch. And was it Dr. Anil Kumar who mentioned the cervical disc disease? If it is cervical disc disease, where will the pain be?
Radiculopathy to the hands.
Where?
Radiating to hands.
Radiating to the upper limb, radiating across the upper limb. If it is lumbar, more likely to be sciatica. So, the nature of the pain, the distribution area of head nerve, and with some long-lasting pains, abnormal sensation in the area of pain. Can you remember these 3, friends? Try to remember them. Because when you are sometimes in doubt, there is no MRI scan that can tell you whether it's neuropathic or nociceptive. Even a nerve conduction study may not give you a clue. So you see what's the nature of pain, where is the pain appreciated, is it in that area of distribution of a nerve or a group of nerves, and is there abnormal sensation in the area of pain. These are the 3 important characteristics. Can you try to remember that? Quality, distribution, and abnormal sensation. So what I would recommend strongly is that in people with pain, certainly if you are running a pain management service, there should be a chart like this, where you are able to mark where the pain is. Pain, say for example, So, doctor, I have the pain is mostly here, but I also have a pain over here. And sometimes I have a pain in the lower back. Next time he comes, you will forget all that. If it is somebody like me, I will forget after 1 hour. So, to remember this, better mark it on a body chart. In our unit, we always do this. Every patient has a body chart where the pain is marked. But how will you assess the intensity of the pain? Is there something called a painometer, like thermometer? Who do you think is most suited to assess the severity of the pain? The doctor, the nurse, or somebody else?
The patient, sir. The sufferer.
Absolutely. Only one person in the whole world can assess one's pain. That is the person who feels the pain. Because pain is subjective. Pain is not an objective thing that you can measure. Pain is subjective. So this tool is used only if the person himself or herself is able to say how much pain there is. And what I would tell is 0 means no pain. Suppose 0 means no pain. What do you really say about the 10? Don't say things like maximum pain or severe pain. 10 is the worst imaginable pain. Worst imaginable pain. So if 0 is no pain and 10 is the worst imaginable pain, how much pain do you have? 45 people, at least 3 or 4 of you must be having migraine or some other headache. How severe does it get? Think. How severe is your back pain when it's on bad days? How severe is your menorrhagia? Oh, sorry, dysmenorrhea. For every kind of pain, you can make that assessment. And remember, nobody else can understand the severity of your pain. So whatever they write, we'll mark. And if there are 3 pains, so here this man has pain down the arm, some pain in the left shoulder, and some pain in the low back. I will mark them as pain A or pain 1 or pain A, pain B, and pain C. For each, I do a scoring. Next time, every patient comes back and tells you, after you have given your analgesic, how are you? A little better, doctor. A little better may mean that from 10 it has come to 9. It may mean that I have no pain, but I am worried that the pain may come back. So this is important. When in assessing pain, you see, remember, all 3 of those pains, you have to assess whether it's nociceptive, neuropathic, or sometimes they can be combined, both nociceptive and neuropathic. So these are the PQRST of pain assessment. What provokes the pain? What's the nature of the pain? Is the pain radiating to some spot? Where exactly is it? And how severe it is? The body chart that I showed shows the site and the severity. What worsens the pain, what relieves the pain, what's the nature of pain, picking, pricking, aching, etc. Is the pain radiating to somewhere? Where is it? And how severe it is? And when did it start? And how long does the pain last? Is it continuous? Is it intermittent? These are the various things. These are the PQRST of pain management. Sri?
Yes, sir. Sir.
No, I was looking for Sri Priya Sri.
Yes, sir.
Have
Sorry,
video,
sir. My
please.
lap is getting stuck. You want the video, right, sir?
Yes, I do.
Just a minute.
Please watch the video, friends. Thank you, Sri. Friends, you all saw the video. That is my colleague Nirmala, Dr. Nirmala, assessing the pain of a person with a low back pain. And believe me, low back pain can be as severe as all that. During the conversation, not exactly in that order, Nirmala found out what worsens the pain, including the movement sideways, cold, etc. Found out that at one point of time, some things help, but not anymore. She found out the nature of the pain, the radiation down the leg, which is the worst pain that Savitri has. She found out exactly the various sides of the pain. In this case, Savitri herself marked it. If your patient can market himself or herself, nothing like this. If not, we do it for the most of the time. The severity of the pain, 10 out of 10. Except in the head, that's what she said. No, not 10 everywhere. She mentioned the duration, continuous pain all the time, and some things that make them worse. Friends, apart from this, was anything else asked and answered or answered?
How is it
What was,
affecting her life?
yes.
Yes.
These are all about the appreciation of pain. But the most important thing we remember, thank you, Shahida, when we started this afternoon, we mentioned we are not treating the pain, we are treating the person. We are treating the suffering. So that was a critical question which made Savitri break down and cry. This is pain assessment. By the time, maybe the inference that Nirmala has arrived at is that she has a low back pain with a possibly neural injury or neural compression pain affecting her sciatica. That she may have a facet joint involvement as indicated by the pain when moving sideways. That she has gradual sensitization worsening the pain all over her body. These are some of the inferences that she has. But primarily, that Savitri is likely to have a neuropathic pain more than anything else. And that is both either likely to be neural compression and possibly neural injury pain also. Now we are more equipped to treat that pain. Now that this assessment is there. And relationship issues, which are very common in people with chronic pain, worsen the pain. And the worse the pain, the worsen the relationships. It's a vicious circle. So that final question is all important. Now, what's the time like? Sri, guys, we have been at it for 55 minutes. I hate doing this to you, ladies and gentlemen. But we have some more things to talk about. Can you travel with me when I venture into a bit of pharmacotherapy? Because in tomorrow's session, Sridevi threatens that she'll be mostly concentrating on opioids and anything else I'll have to deal with today. Please see the WHO ladder, which was brought out by WHO in 1986, which has revolutionized cancer pain management the world over. And some of the fundamental principles are, as far as possible, give the analgesic by mouth. It's a modern disease that, if at all possible, doctors will give paracetamol as intravenous injection. And can I give you some homework? Please find out how much it costs. Also find out how much a single dose of paracetamol oral costs. Bioavailability of the oral preparation is excellent. except in the patient, in the patient who is unable to take it orally, you can give it by suppository in adequate dose. So the indication for intravenous paracetamol, which is so expensive for most people in our country, and which has to be given intravenously, is minimal. By mouth, by the clock, by the ladder, suited to individual, and attention to details. These are the recommendations given. And if Sridevi promises to cover opioids tomorrow, or whoever it is, not Sridevi necessarily, Sridevi is orchestrating the whole thing. That's why he said Sridevi. And that means non-opioids and opioids, step 1, may not be discussed tomorrow. See, friends, lower down in the order, not class enough for Sridevi. She wants us to do it. Okay, let us. Hey, what are adjuvants? When you say an adjuvant analgesic, adjuvant, does that make any sense to you?
So that is given with an analgesic, not primarily meant for the pain relief, but it add to the effect of analgesic.
Very good. Anon, but not that effective. Bhanu, that may not be so. As Priya said, these are not primarily analgesics. These are drugs given along with analgesics, usually, or by themselves. Adjuvant analgesics do not by themselves usually confer analgesia, but it treats a particular problem, which may be the cause of the pain or the mechanism of the pain. I have given an example here. Corticosteroids reduce peritumor or perineural edema. If there is compression of a nerve root or a nerve by a tumor or anything, it will reduce the peritumor edema, relieve the pressure on the nerve, and give pain relief. If it is a lung cancer and that's causing pain, corticosteroids may give some pain relief by reducing the pressure on the nerve, some relief. But Bhanu, why I said it may be very effective also. Think of other causes of neuropathic pain. Sorry, other causes, other adjuvants that may help. What can you think of? Anybody? Please unmute and speak. Sri Priya, if somebody puts in something from the chat, on the chat, tell me.
Yes.
Anybody? Apart from corticosteroids, any other adjuvant?
Alpha-2 agonistic agents, sir, like
What kind of
dexmedetomidine.
pain? What kind of pain?
Yeah, it is acute postoperative pain, sir.
Yeah, but how about vascular pains? Maybe they may help. Maybe partially. Okay. Alpha agonists have a central mechanism of action. Who said that, Priya, or somebody else? Will you please name a drug?
Dexmedetomidine and clonidine, sir.
Dexmedetomidine. Oh my God, 1.5 kilometers long name. Dexmedetomidine. Dexmedetomidine. Okay. Anything else? There speaks the anesthetist. Anything?
Tricyclic antidepressant.
Tricyclics. Hey, if you are using it to treat depression, why are you mentioning it here? Not as antidepressants, but tricyclic antidepressants help in neuropathic pain by its action on the descending inhibitory pathway. So what kind of pain will in what kind of pain will we use tricyclics? Who answered that? Please tell me your name.
I'm Dr. Harsha Patel.
Harsha, what kind of pain will be helped by tricyclics?
We usually give in a chronic type of pain.
Yeah, but particularly in neuropathic pain, Harsha.
And radiculopathy usually.
Radiculopathy also, but certainly any kind of neuropathic pain, we may use it. Anything else? Tell me, friends, many of you have young children, right? And young children often, all of a sudden, clutch their tummy and scream in pain. What do you give them?
Antispasmodic.
Antispasmodic. So earlier, when you mentioned not very effective, it can be very effective. That will be the only thing that will help relieve that pain. Okay, antispasmodics. I'm not going through all the list, but now that you mentioned tricyclics, any other kind of medicine that you use in neuropathic pain?
Pregabalin.
Some response coming in.
Dr. Vijay, absolutely, pregabalin. But I hope you will remember tricyclics first, the inexpensive things first, before we go on to the very expensive drug, because many of these things are necessary for a long time. And for any poor patient, the cost can be horrendous. Antispasmodic, okay, many more, like tricyclic and
Few
yeah.
chats, sir, muscle relaxant, ketamine, and gabapentin.
Okay, very good. All of them are correct. I was about to type in skeletal muscle relaxants, but
Centrally acting, sir. Like baclofen.
yeah, skeletal muscle relaxants can be several. So these are all examples. Adjuvants. So sometimes they may be the sole means of treating pain, like an antispasmodic, or more often they are adjuvants along with other analgesics. So where is my ladder? In my ladder, I showed non-opioid or adjuvant. I said we are dealing with only step 1 today. Sridevi has given me a strict warning not to touch step 2 or step 3. Know your place, stay in step 1 is what she told me. So we talked briefly about adjuvants. I'm not going into the individual drugs and dose, etc. now. Non-opioids. Non-opioids. Usually there are many others. Nothing is very important. So please don't bother about nefopam and so many things. The commonest used are paracetamol. Hey, paracetamol is an NSAID or no?
NSAID.
Well, some textbooks include it. As I said earlier, it is centrally acting. All the other non-steroidal anti-inflammatory medicines are predominantly peripherally acting. So these are the non-opioid analgesic ordinarily used. We'll talk a little about them and then stop. This is not only about treating your patient with cancer or something else. This is about you yourself. You must be swallowing such a lot of analgesics time and again. This is about managing our own family also. Remember it, even if you include it in paracetamol among NSAIDs, it's unlike all other NSAIDs. It has negligible anti-inflammatory action in clinical dose. In the laboratory, if you trouble poor mice and give a toxic dose, it will have. In clinical dose, hardly anything. They have a predominantly central action. They are safe at 12 to 15 milligram per kg, 4 times a day. Will you note that point? Those, try to remember. Remember, Ravish Ranjan, you have to remember this yourself when you are swallowing this tablet.
Okay, sir.
What is you don't have to tell me. but you calculate your body weight and find out how much will be appropriate for you. Everybody calculate for yourself. You say, get your mobile phone and use the calculator if you have to. What is the appropriate dose? Many of you, I suspect, may be taking 500 milligrams, and very often that is inadequate for most adults. So if you are 60 kg, we are talking about taking some 650 milligram tablet. If you are 80 kg, we are talking about taking 1 gram, 1000 milligrams, and at least 6 hourly. Remember this for your child also. Very often you may be inadequately dosing your child when the child has a fever, or you may be overdosing. Please try to remember this dose. And here is a little bit more of information about you, for you. Even in the presence of borderline liver disease like cirrhosis, paracetamol is safe. Please note this. Sri Priya will be giving you the presentation. Note the reference, but there is a problem. If you prescribe paracetamol, most physicians will say you are mad. Look at Dr. Ravish. He is prescribing paracetamol to somebody with cirrhosis. But it is safe in people with cancer, particularly. Unnecessary suffering with pain or fever occurs, and it is reasonably safe. Can you give it to, children in dose of upper limit of normal? Yes. 15 milligram per kg is safe and effective, 4 times a day. If the child has severe fever and is coming back too soon, you may even give it 4 hourly for a couple of days. That's okay. There is a wide margin of safety. Usually in a healthy liver, person with healthy liver, toxicity occurs only at 90 milligram per kg per day. And even if you are giving 15 milligram per kg per day, you still are not giving a toxic dose. Now, these three I am going to tell you now about all other NSAIDs. Paracetamol also may be a gastric irritant for some people, usually not significantly. But for all other NSAIDs, you have to remember these three. I earlier mentioned 3 features of neuropathic pain. Remember, even if you forget that, it's okay. You cannot afford to forget these 3 points all your life. Every time you are picking up your pen to write a prescription for an NSAID, remember to ask, is this person prone for gastric irritation? Is the person prone for kidney damage, or does he already have a kidney damage? Does he or she have a bleeding tendency? Okay, there are problems. So what are you going to do about it? So every time you write a prescription for NSAID, I would strongly recommend a gastroprotectant even before that. Your NSAID is always prescribed after food. How about pantoprazole or omeprazole? A proton pump inhibitor. When should it be taken? Before food or after food?
Before food,
Usually optimally effective on an empty stomach.
20 minutes before.
Ask the person to take it as soon as he or she gets up in the morning. 1 dose a day. Twice a day is not necessary. It has been shown that pantoprazole, very often given BD also, does not improve gastric protection. Once a day, empty stomach. But NSAIDs are always given after food. Kidney damage is a real issue. It is not a remote possibility. It is very real. The one thing that you have to tell every single patient given NSAID, when you are taking this tablet, drink enough water. If you cannot drink water, don't take the tablet. If you are going to take a bus, especially women traveling by overnight bus, etc., just because to avoid going to the dirty toilets and routes, you will stop taking fluids. Very often it happens. Men also. And then you should not take this. In a day, it can significantly damage your kidney. Of course, if you have pre-existing kidney damage, it's contraindicated. It doesn't ordinarily worsen bleeding. Let me not overemphasize this. If you give it, bleeding tendency is not going to worsen. If you take it for dysmenorrhea, menstrual bleeding is unlikely to increase. But if the person already has a serious bleeding tendency, a platelet count is low, or it is a patient who's, if you are having a hip replacement surgery, the person is having a spine surgery where from the bone bleeding is more likely, this had better be avoided. Can you remember these three? Hey, close your eyes and think of a human body. Think of the stomach, the kidney, and the blood flowing between them through the aorta. Stomach, kidney, blood. Stomach, kidney, blood. Stomach, kidney, blood. Every single patient, you have to think about this. The most deadly painkiller is not any opioid. The deadliest painkillers are NSAIDs. The commonest reason for kidney acute renal failure in our country is iatrogenic, and among all the medicines, NSAIDs are the most common. Any comment about this? Friends, everybody, when you swallow NSAIDs or give it to your family, will you remember this? Protect the stomach, ensure hydration, avoid bleeding tendency. Okay. But what's your favorite NSAID? What do you take? You want to put it upon the chat box? Okay, NSAID other than paracetamol. Favorite NSAID other than paracetamol. Aceclofenac. Aceclofenac is very popular in India compared to other countries. Is it just pressure from the industry, I wonder? Okay, diclofenac, aceclofenac.
There is one ibuprofen and a combination, sir. There is a combination of diclofenac and paracetamol.
Nimesulide. Meftol is mefenamic acid. I will not comment on the muscle relaxant, which would be an adjuvant. Generally, we frown upon combinations of medicine, but well, I know that it will have some place. Ibuprofen and paracetamol combination, Vikina, is slightly objectionable because the duration of action. Paracetamol has only 4 to 6 hours of effect, not more than that. Whereas ibuprofen has 6 to 8 hours of it. So there will be a difference between the duration of action. Anyway, you all, I'm going to try and persuade you, many of you, to change your practice of choice of NSAID. Oh. Yeah. Wow. So the oldest among you may remember a miracle drug called rofecoxib coming into market, and later they got into serious trouble because they had suppressed information that the drug was dangerous. There are serious concerns about the cardiovascular safety of NSAIDs because use of NSAIDs was linked to an increase in heart attacks and strokes, increased coronary and cerebrovascular events. So they brought in COX-2 selective drugs, which are certainly seem to be safer for the stomach, though gastric irritation is not zero. But please remember, COX-2 selective drugs are as likely as non-selective NSAIDs to cause toxicity to kidney. COX-2 selectivity does not offer protection of the kidney. We must remember that. And COX-2 selective drugs seem to be more likely to increase the chance of stroke and myocardial infarction. So if you are very fond of etocoxib, which was brought in when rofecoxib was banned, let me disillusion you. The only person who may benefit from it is somebody who doesn't tolerate anything else because of the stomach, and for short-term use only because of these combinations. Long-term etocoxib is a strict no-no. In Denmark, I have given the reference here. It will be good to study this. And this is something that Sridevi and I and my colleagues changed our practice. Till then we were using diclofenac as the first choice. With this study, when this study came out in 2011, we changed it. Increased cardiovascular morbidity and mortality was observed with rofecoxib, diclofenac. And we believe that aceclofenac may be more or less similar. High dose of ibuprofen. And the safest, according to the study, the huge, enormous study in Denmark, they showed that the safest was ibuprofen limited to 400 milligram TED or naproxen 500 milligram BD. Ladies and gentlemen, I repeat, the safest NSAIDs, as we know today, I know 12 years, 13 years have passed, still we have nothing to disprove it. Ibuprofen 400 milligram TAD after food or naproxen 500 milligram twice daily after food seem to be the safest for the heart and the brain. Of the two, generally it is felt, though not proved, that ibuprofen is easier on the stomach than naproxen, but it's also personal variations. So those who are taking diclofenac, aceclofenac, etc. on yourself or your family, please consider changing your ibuprofen 400 milligram TAD or naproxen 500 milligram BD. And I am making the statement that I have no shares in any companies, any company at all, even that alone. I am not making a pitch for ibuprofen or naproxen because I have any personal interest. So in short, we are saying that these are pretty much dangerous drugs, not to be prescribed irresponsibly. Think of the stomach, think of the kidney, think of the bleeding tendency, and use ibuprofen or naproxen. And remember to avoid it in presence of respiratory infections. This is another important study that came out 6 years back. Would you believe this? In the presence of respiratory infection, the chance of myocardial infarction seems to double. There's some doubt that it is related to the carbon dioxide concentration in the blood, but we are not sure. And particularly, if you give NSAIDs and respiratory infection. See, if you are giving only NSAID, this is the incidence. And if you are giving it along with more than twice, the incidence goes up. And if it is parenteral NSAIDs, it goes up significantly. So if you have a respiratory infection, especially in vulnerable age group, stick to paracetamol, not to one of the other NSAIDs. So long session, you must all be tired. The important points that we made were pain is an emotional experience. Treat pain early, and in continuous pains, treat by the clock. To the two people who wanted to give analgesics SOS, paracetamol and SOS, no. If it's continuous pain, give it by the clock. Distinguish between nociceptive and neuropathic pains. Remember the adverse effects of NSAIDs, stomach, kidney, blood. And the safest today seem to be ibuprofen and naproxen. The rest of the ladder will be leave to Sridevi for the future. I see that we still have a few minutes left for any important questions, comments, or observations. I'm sorry that I have not been monitoring the chat box and
No, sir, there is
Anjana,
only
certainly,
one
Anjana,
request
Sripriya
of
will.
slides.
Sripriya will. Sri, have you shared the slides already?
No, sir, we will be sharing this.
No, don't. Because I made some slight changes to it. Send only what I'm giving you now, not the earlier one.
Okay, sir. Sure, sir. For the kind attention of everyone, actually, we'll be sharing the slides along with the records to the IECO platform as soon as the recordings are available. So kindly give us at least 48 working hours to get the same done. So
We can take up a few questions if you have any.
Dr. Saeed Ahmad, aceclofenac is a variant of diclofenac. It has not gone through the detailed evaluation that diclofenac has had. Our assumption, though it is believed to be easier on the stomach, our assumption is unless its safety in cardiovascular and disease and stroke is proved, I wouldn't use it. When I need to, rarely, I take ibuprofen, not aceclofenac.
Sir, a question on piroxicam.
Piroxicam, the big advantage is that you need to take it only once a day. But there's also one other thing about NSAIDs. There seem to be considerable individual variation. Some people respond more to one than to the other. Apart from that, between the oxycams like piroxicam, meloxicam, etc., there is little to choose. And as I said, studies on these many NSAIDs are limited. There are so many drugs, right? I wouldn't believe every study. If somebody published the study, I'll go to the fine print and see who funded the study. Did a drug company fund it? So the advantage of the study Denmark study that I mentioned was it was done by the government. No vested interest. Priya, shall we go on to tramadol next week? Next day, tomorrow, right? Sorry, because it's one of the opioids. We did not cover tramadol. Let us do it tomorrow. Sri, you will be handling, or whoever it is will be handling.
Dr. Sunil will be touching upon weak opioids.
Okay. Oh, Satyendra, very valid question. Illiterate patients who cannot count 0 to 10 may not make sense to them. Generally, in most places, In Kerala, we are fortunate because most people can count. If not, many people use a rupee scale. 1 rupee is maximum pain. Half a rupee, etc. Rupee or coin scale is used by many people. But if some patients are very much in pain and irritable, and you go and say 0 is no pain, 10 is the most worst imaginable pain, how much is yours? They will say, I don't know all that. I have terrible pain. Or some people will say 10. No, my pain is 100. Meaning that it's much worse than what they could imagine. And there's even this story from Kidwa Institute in Bengaluru, where the rupee scale was administered. And the person took out his purse and poured out all the money onto the table and said, put in your money also. This will not be covered by 1 rupee. My pain is as severe as all that. But that also is fine. You just write down what the patient says. Dr. Vijay, paracetamol, can I see you, Dr. Vijay? Depends, doctor, on your body weight. For me, 1000 milligrams will be a terrible overdose. I am 52 kg when I have had a heavy dinner. That is too much for me. Whereas for an 80 kg person, the nociceptors will laugh at 500 milligram going in there. So especially in Western countries where the average body weight is more, they use 1 gram tablets. So calculate for yourself. If your body weight is 80 kg, 1000 milligram tablet is good for you. For face scale, Sridevi, while I am talking, can you quickly find a picture of the face scale?
Yes, sir.
From somewhere, a face scale is something that is used for children. A happy face on one extreme and crying very much on the other extreme. How do you feel is the question asked to children. And Dr. Bhanu Prakash is saying that we can use it also for illiterate people. So they will find a picture for anybody who is not familiar with it. So sometimes, Dr. Satyendra, even face scale or nothing may work. Say, suppose somebody in dementia, always be sensitive about possibility of pain in people who are unable to express. Somebody who is aphasic, somebody semi-conscious, somebody, a child, small child who cannot even do face scale. So when somebody is unable to understand or unable to accept, express, you will just have to look for the telltale signs. This person with dementia may be sitting like this, and the eyebrows may be furrowed, LNC may be flaring, and you may ask the family member, is this something recent? And that may indicate pain. So sometimes a therapeutic trial is the only way you can find out. Give a tablet. This is the FACES scale that doctor was talking about. This is 0, this is 10, the worst suffering. Thank you, Sri, for being so resourceful.
If there are no more questions, maybe we can wind up today's session.
Let us go home. Hey, Shahida. Shahida, I must express my appreciation for your background. Oh my God, half the time during the session, I was looking at those flowers. What absolutely stunning flower. Thank you, everybody. Sri and Sri, thank you.
Thank
Bye-bye.
you.
Thank you so much.
Thank you.
Thank you so much,
Thank
all
you.
the participants. Tomorrow we'll be
Thank you.
discussing in detail about opioids. So focusing more on step 3 and touching upon step 2. That will be a very important session because we'll be focusing more on morphine and a little bit on methadone. Till then, it's bye from our side, and
Simple
hope you
request, madam.
join.
Simple request to madam and sir. Hello.
Sorry. Yes, Dr.
A
Sharida?
simple request, madam. Actually, from
Yes.
tomorrow, I'm going for Mysuru South Zone conference.
Okay.
So I don't have about the connectivity. As far as possible, I'll try to be online.
Yeah, please try.
Yeah, because from 9 to 13th, we are having South Zone Conference ISA at Mysuru. So I'm invited as a speaker there. So just for that reason. But
Please try.
Madam, I try my best. Thank you. Thank you.
Thank you so much, everyone.
Thank you everyone for joining in. See you tomorrow, same time. Till then, everyone take care. Bye-bye.